5 years, yes. So fellowship is two parts mainly. Part one, which is usually the basic subjects, and then we have a we call it Kijani Saldu, Kibolnam.
In FCPS, there is two parts. That is, first 2 years basic training, and after that they will do the midterm exam. And
right.
after that they will do the clinical training.
But before midterm, they have to pass the FCPS part 1, and then after 1 year they go for midterm. Which after these 3 years, they are basically an anesthesiologist, but for the rest 2 years, they have their specialized training. So after 5 years, they complete their training and then they appear for the final exam. And in MD, this is again phase 1 and phase 2. Phase 1 is relatively basic, and that is 2 years, and then phase 2, it's 3 years, yes. Phase A and phase B, we call it.
Okay, that's good.
We have very, according to our population, our anesthesiologist number is very low.
Okay, how much is it?
It's
approximately?
It's something like I calculated a few days back.
Around 3,500, sir.
Yes, that is with the diploma and all the fellowship and MDs. It's something like 3,000 to 3,500 for a 180 million people.
Okay. Yeah, I can understand.
So and
now the regional,
and also
the number of regional fellows will be somewhere around how much will be regional anesthesia fellows, and
we actually don't have any regional anesthesia fellowship.
Fellows,
we are trying to open that. We'll soon be opening in university. We have started the pain fellowship for a year.
Okay.
And we are planning to open the regional anesthesia fellowship also in the university. So that is our plan. And during this 5 years course, they have to perform regional anesthesia. There is in their logbook, they have to complete that logbook, and they have to perform a certain number of cases in all types of regional. So after only that, they can get, they can complete their training. Shall I to কথা বলো?
We have 36 participants, and our time is 9:30, sir. So we hope it would be around 60 to 70.
Yeah, I'm ready. And whenever you say, we can just go.
When I went
we can wait for 5 more minutes, and then
yes, sir. Our
it's up to you.
mentor, Dr. Iqbal sir, is here.
Hello, good evening, everybody.
Good evening. Good evening,
Dr.
Iqbal.
It's nice to see only 3 people so far, is it?
Sir, 42.
Oh, 42. Sorry. I didn't say that. I think there's enough people. for Dr. Sivasanugam.
You can call me Shiva.
Shiva, sir. I
Yes,
don't go
Shiva,
for his
yes.
full name.
Shiva,
Forget it. It's
Shiva,
too complex.
Shiva,
You can call me
Shiva is
Shiva.
easier.
Yeah. Yes,
He's only Shiva
yes.
to me.
Okay.
Yeah.
Good. I think you could start, couldn't you?
Sir, 5 more minutes, sir.
All right, fine.
Yes.
I just apologize for being a wee bit late, and I will leave a bit early. So if it is, I hope you will understand that I have got some of the work about a quarter to 11. Is it quarter to 11? That's right. Yes.
We'll be finishing by that, sir.
I hope so. Yeah. Thank you.
Okay. Good evening, everybody. I welcome you all to this monthly webinar of Bangladesh Society of Regional Anesthesia. And today we have a very good friend of mine. He is Professor Shiva Shanmugam. I got it right?
Yeah.
And who is only Shiva to me, a very good friend and colleague.
Yeah.
And he is also a very good friend of Ashoka, who was here just in November. We all know him. So he's also a very good friend of Ashoka. He's a professor in Department of Anesthesia and Pain Medicine in Mahatma Gandhi Medical College and Research Institute in Puducherry, India. His special interest in ultrasound guided, as we all know. He will be talking to us on regional anesthesia today and acute pain and vascular access. He is also the program director, fellowship in ultrasound guided regional anesthesia. And he's also a very important member of Academy of Regional Anesthesia of India. So I know his work, I know his interest, and I know that he is one of the best in this region. And I hope we all listen to his informative lecture, and we learn from each other. Yes, Siva?
Yeah.
Thank you very much.
Thank you. Thank you very much, Professor Aziz, for such a wonderful introduction. And I think, am I audible? Is my screen is visible?
Yes, it is.
Yeah. Okay. So thank you very much, Aziz sir and Dr. Iqbal, for giving me this wonderful opportunity. I'm really honored and humbled to share our experience and learn, as well as Professor Aziz said. And as far as of the best or the most beautiful thing or the highest possible thing that we can do to any professional group is teaching, training the future anesthesiologist. So in that context, and Professor Asif and Professor Iqbal is doing a great job in Basra, and then trying to impart the importance of this and then the safety profiles and what it can do to the patients, the regional anesthesia. So I really bow down to your efforts and your passion and commitment toward this noble cause. So with that words, I thank once again the Basra for giving me this opportunity to talk about how this ultrasound helps us in doing our central neuraxial blocks. Going to the disclaimer, I have no conflicts of interest. The many techniques that I am going to describe in this presentation are at institute and personal level experience. So if you go and look at into the literature, you may not find an evidence for the benefit, the techniques that I'm going to speak in this presentation, but keep it in record. In a due course of time, you will see it. So this presentation is exclusively about experience sharing. It's not information sharing. So you may not find much of evidences. I'm going to share what is our experience in our institute in the last about 5 to 6 years in this ultrasound guided spinal sonography. Even though we have traveled in ultrasound guided regional anesthesia from 2010, about 15 years, the journey of central neuraxial blockade in the last 5 years, I'm going to share with you. So the good outcome of any technique depends on the plateau portion of your learning curve. If you wanted to decide some technique is good or bad, first you need to reach a plateau portion of the learning curve of a particular technique. Then only you can able to decipher whether it is good or bad. So as far as the spinal sonography is concerned, you need minimum of 50 successful interventions. Then only you are in a position to decide whether a technique is really impactful or not. And don't try to understand every technique what I'm going to speak to you, because it's very difficult to explain to you the spinal sonography through PowerPoint. So you just sit back and enjoy. You just see how we have transformed, how the ultrasound has helped us in doing these difficult central neuraxial access. You just look at it. Don't try to understand. Just sit back and enjoy. And be assured, if you wanted to learn this skill, if you travel, you will get it. So how I am going to place this presentation today is like this. So as you all know that the spinal sonography is we are going to intervene in our patients in these 4 areas. One is lumbar, thoracic, cervical, and caudal. These are all the interventions that we are going to do with our patients in our everyday life. So my presentation, first I'm going to explain about the ultrasound views of the lumbar spine, and then using those views, how to surface mark, and then how to do the ultrasound assisted interventions using these surface marks, and then ultrasound guided interventions. Then coming to the thoracic, similarly, first I will explain you what are all the views. Using those views, how we are going to surface mark on the skin. Based on the surface mark, how we are going to introduce our needle and achieve our central neuraxial blocks. And then ultrasound guided, real-time guided interventions. In cervical spine, I am going to explain you only a real-time guided interventions, and in caudal block, real-time guided. There is no ultrasound assisted technique, and some of the videos how we have navigated difficult central neuraxial blocks using these skill sets. So that is how my presentation is going to flow through today. So as you all know, whenever we use an ultrasound, the first and the foremost is the equipment that we are going to use is an ultrasound machine. What is the optimal setting that I need for spinal sonography is the first question that we wanted to answer. The typical equipment setting is as follows. Commonly, we use a curvilinear probe because our target of our interest is between 3 to 5 centimeters in our population, like Indian and in Bangladesh. This is what is the commonest depth at which we will look at the central neuraxis. And commonly, we select a musculoskeletal preset. If your machine has got a spine preset, that is great. And then usually, even in the low frequency probe, we will try to select the least frequency. The curvilinear probe is going to fire between 1 to 5 megahertz. Within that 1 to 5, we wanted to choose between 1 to 3 megahertz. So by choosing a penetration mode, we will instruct the machine to fire between 1 to 3. Something on the screen, like a central line or M mode cursor, because we wanted to align our target onto the middle of the screen. So here we will use the central line as a cursor to align into the central line on the image. And then the dynamic range. As far as the dynamic range goes, we wanted to keep it onto the lower side. We are going to look at only the bony landmarks. So if you keep the dynamic range at a lower level, the bony landmarks are going to be visible much better. So the contrast ratio going to be increased. So we wanted to keep the dynamic range to the least. And then the overall gain. This is the first button that we always try to rotate. But as far as spinal sonography concerned, we wanted to keep the overall gain at the neutral or little lower, because here we wanted to see the bony landmarks clear. If you increase the overall gain, your needle visibility is going to be challenging. So as far as the spinal sonography concerned, we are going to have a low threshold for the overall gain. We wanted to keep the image a little darker so that we can see the needle better. The depth, we wanted to keep our target at the middle of the screen because in Sonocyte machine, the focal point is set at the middle of the screen. In machines where you can adjust the focal point, you can place wherever you want. But in Sonocyte, it is set at a default at the center of the screen. So we wanted to keep it at the center. And usually you activate tissue harmonic imaging, which is a compound imaging that is available in most of the latest machines, that is going to help us to see our target much better. So these are all the typical ultrasound equipment setting that we wanted to set up in our equipment when we are trying to do a spinal sonography. The next one is coming to the ergonomics. What position you wanted to put into the patient. In our practice, whenever we do a real-time interventions, that is ultrasound guided interventions, we wanted to place the patient in prone position. Whenever we wanted to do ultrasound assisted interventions, we wanted to keep them on sitting position like this. And you know always the best ergonomics, the simple principle is the vision of the performer, the probe and the needle, and the ultrasound screen all has to be aligned in a straight line. So this is the best ergonomics that we need to meet. So the bottom line of a best ergonomics, you should ensure that the ultrasound image is exactly in front of you and the probe is in front of you. This is what you need to look at it. So coming to the core competence, if you ask me, what is the core competence that I need to develop to master the skill of spinal sonography is these three things. First is you should understand the sonoanatomy of the spine. This is a knowledge component. Once you understand how the image has been generated, the next thing is you need to acquire the skill of acquiring an optimal ultrasound image. For that, you need to know how to handle the probe as well as the machine to get the optimal image. And then the second skill that you need to develop, once you get an optimal image, the next skill that you need to work upon is getting the needle, visualizing the needle in a low frequency probe. So one knowledge that you need to acquire is understand the sonoanatomy. Two skills that you need to master is, one is you should be able to acquire an optimal image by doing an optimal probe maneuvering, and then you should be able to look at the needle effectively under low frequency probe. So these are all the three core skills you need to work upon to become master in spinal sonography. Having said that, now first let us look at the lumbar spine, which is a everyday practice. So because this is a day in and day out, we are going to look at our lumbar spine. So now first I'm going to explain to you what are all the ultrasound windows through which we are going to look at our lumbar spine. So now there are 6 views through which we can look at it. There are 3 longitudinal views, 2 transverse views, and 1 cross view. The 3 longitudinal views are these 3 things. There are 3 longitudinal views. One is paramedian, sagittal, transverse process view. Paramedian means this is a midline, and whatever the position that you take parallel to the median, we will call it as a paramedian. The probe orientation is sagittal. So the first 3 terminologies, paramedian, sagittal, is just dictates where you keep the probe and what is the orientation of the probe. The next terminology, the transverse process view, is what structure you are trying to look at it. So if you look at on the image, if you place the probe across the transverse process, it is known as paramedian sagittal transverse process view. And from there, if you move your probe and arrive at the, I request the host to enable my video. I couldn't able to activate my video.
Okay, sir, I'm doing this, sir.
Yeah. Because in between I can switch on and switch off. Yeah.
It is, yes, sir.
Yeah, now it's visible. Okay, thank you. You can see my screen, isn't it? Is it well visible, Salahuddin?
Yes, sir. It is visible, sir.
Yeah, fine. So now, once you move your probe, once you arrive at the articular process, it is known as articular process view. And then if you, from there, if you make an oblique tilt, it is known as a paramedian sagittal oblique interlaminar view. These are all the 3 longitudinal views, and then 2 transverse views. If you place the probe across the spinous process, it is known as a transverse spinous process view. If you place the probe across the interspinous process, between the 2 spinous process, it is simply known as interspinous process view. And then finally, a cross view where you don't tilt your probe, but you rotate your probe. So that is in the paramedian plane, you just make a 20 to 30 degree clockwise rotation. That is known as a paramedian cross view. So these are all the 6 ultrasound windows through which we are going to look at the lumbar spine. Now I will explain you individual views so that you will understand what we will see in the ultrasound image. When you place the probe across the transverse process, the ultrasound beams are going to cut the transverse process like this. And as you all know very well, in the ultrasound image, the bones looks like a clear hyperechoic line with a shadow below. So once you put the probe across the transverse process, you will see an intermittent hyperechoic line with a gap in between them. In the gap only you will see the muscles. Because the transverse processes are intermittent, you will see clearly a intermittent hyperechoic line. So once you slide the probe, arrive at the articular process, these intermittent hyperechoic line will become a continuous hyperechoic line, because the articular process is going to interact with the other articular process. So from there, if you make an oblique tilt, it is known as a paramedian sagittal oblique interlaminar view. This continuous hyperechoic line will again become an intermittent hyperechoic line. So, but between these gaps, you will see the interlaminar space. So these are all the three longitudinal views. Now let us look at how the ultrasound image looks like. So in the paramedian sagittal transverse process view, you will see the bony shadows like this. Moment you look at the bony shadows like this, you can clearly understand it looks like a trident. So they given the name of trident sign for this paramedian sagittal transverse process view. Because the transverse process looks like a finger-like projections, since they look like a trident, they've given the sign of paramedian sagittal transverse process view. The sign given is trident sign. Similarly, when you arrive at the articular process, these intermittent hyperechoic line become a continuous line. It looks like a hump of a camel. They called it as a camel hump sign. And then from there, if you make an oblique tilt, this continuous hyperechoic line again become intermittent. Since it looks like an head of an horse, they called it as an horse head appearance. So there are three views and three pattern recognition. As you all know, the patterns are very important for us because we can communicate effectively between each other. So if I say trident sign, you can understand, okay, the transverse process looks like a finger-like projections. The articular process interacts with one another, so the intermittent line will become continuous. It looks like a camel hump. So once you arrive at the interlaminar view, this continuous line again become an intermittent line. It looks like an horse head appearance. So these are all the three pattern recognitions given for three longitudinal views of the lumbar spine. Now let us look at the transverse views. If you place the probe across the spinous process, it will cut the bone like this. So the ultrasound image is going to look like this. So now since it looks like a tower, you know that this is the spinous process and lamina on either side. This is known as a tower sign. Similarly, if you slide your probe between the two spinous processes, the tower is not going to be there on the middle. Instead, you are going to see two articular processes. This is the right articular process, this is the left articular process, and two transverse processes on either side. The ultrasound image is going to look like this. So they have seen that since it looks like a head of a cat, that is the two ears corresponds to two articular processes, and the mustache of the cat corresponds to the two transverse processes on either side. So they called this transverse interspinous process view as a cat head appearance. So I have given 5 pattern recognitions for 5 different views. So this is how the ultrasound is going to look at the lumbar spine in 5 different windows. Now we will look at the cross view, where we are going to rotate the probe in the paramedian plane. When you rotate, what happens is we are going to see a lamina of the lower vertebra in the lower part of the image and the spinous process of the upper vertebra in the cephalad end of the image. In between the two, you will see the posterior and anterior complex. So this is known as a paramedian cross view. So now we will look at a quick video how these images transform from one another. So now we are going to from the paramedian sagittal transverse process view, you can clearly see the trident sign now. From there, if you slide the probe slowly towards the midline, you will see the camel hump signs where these intermittent lines will become a continuous line. From there, if you make an oblique tilt, you see a sawtooth appearance. And then now we have come to the transverse view where you will see the tower sign clearly. And then between the spinous process, if you move your probe, you will see a clear-cut cat-head appearance. This is one articular process, that is another articular process, and then two transverse process on either side. These are all the 5 different views. And this is the cross view, where you will see the lamina on the lower end, and then the shadow of the spinous process on the upper end, posterior and anterior complex on the middle. So these are all the 6 views through which we will look at the lumbar spine. Now we will see, using these 6 views, how we can do our ultrasound assisted interventions. Whenever we say assisted, what do we mean is, we will, by using an ultrasound, we will surface mark and drop the probe. Based on the surface mark, we will introduce the needle. Whereas real-time guidance, what does it mean is, you will see the entire needle journey through the ultrasound. So ultrasound assisted is based on the surface marking, whereas ultrasound guided is we are going to look at the needle visibility throughout. So now let us look at how to use the ultrasound assisted technique. Here I am going to describe one technique that is known as box. So this is again an unpublished data. You need not worry about it, you just listen to it. So we are going to make 4 lines on the back of the patient using 4 different views. First, we are using a paramedian sagittal oblique view. We are going to draw the midpoint of the interlaminar space. That is step number 1. Step number 2 is we are going to rotate the probe in a transverse axis. We get the tower sign and make the spinous process. And then we will slide our probe little below, where you will see a clear-cut catted appearance. And then we are going to draw a line that is known as an horizontal articular process line. And then the 4th step is you slide the probe towards the lateral side, identify the articular process and make a vertical line. So I will show it in a video, you can clearly understand. So now in this view, you can see we are sliding the probe through paramedian sagittal oblique view. We arrive at the desired interlaminar space. And then we mark the first horizontal line that is known as a Mills line. And then we turn the probe, get a tower sign, and then mark the midline. So this is known as a spinous process line. Then we slide the probe. And then once we get the articular process, we will make an horizontal line. This is known as a horizontal articular process line. And we slide the probe laterally to get the articular process into the center and make one more vertical line that is known as a vertical articular process line. This is a spinous process line. This is vertical articular process line. This is horizontal articular process line. And the top line is the Miss line. So this is what is the final marking. There are box, you will get it. The center line is a spinous process line. The top horizontal line is a midpoint of the interlaminar space. The second horizontal line is a horizontal articular process line. In this box, we are going to mark 3 points. So this point is known as midpoint of interspinous space. Between these 2 vertical lines, this midpoint is known as a para-articular process, and this point is known as a Mills point. So you don't worry about all these points. So this is how we will do the surface marking on the skin. So now how to use this information? So if you introduce the needle at the lower end of the box, this is known as Miss point. That is the space between the 2 spinous processes. So in this point, you need only the cephalad angle. So if you introduce the needle, you need to make only the cephalad angle. The next point is a para-articular calcified. We will take this point to access the central neuraxis. And the third point is a Mills point, where we will do only the mediolateral angle. We will not do the cephalocaudal angle. So these are all the 3 points as of now has been explored. The Miss point and the Mills point has been explored, whereas the para-articular point is the highest success rate point that we have found. So which you have to understand, our interlaminar space is placed little higher than our interspinous space. And then you are palpating it at a distance from the skin. So that is why you need to make a cephalad angle from the skin to reach our interlaminar space. So among the 3 points which offers the shortest distance is the Miss point. The next one is a para-articular point. The third one is the Mills point. So don't worry about these points. You just think about that these are all the various needle insertion points have been explored. Among the 3, the para-articular has the highest success rate. Why? Because you know very well in elderly patients, the midline is calcified because of the calcifies ligaments, you need to come to the paramedian. What distance we need to come upon is dictated by this para-articular point. When you come up to the success rate is very high, and the first pass success rate is very high when it compares to the Mills point. So now we have seen how we do ultrasound assisted lumbar spine interventions. Now we will look at how we will do real-time guidance. For that, I am going to prescribe one ultrasound window, that is a paramedian cross view. So here what we will do is we will place the patient in prone position, oblique view, and then rotate the probe. Now here you see, first we will look at the paramedian sagittal oblique view and then slowly rotate the probe in a clockwise manner so that you will get a cross view where you will see the lamina of the lower vertebra, spinous process of the above vertebra, and introduce the needle from caudal to cephalad. So this is the lamina of L3. This is the spinous process of L2. This is the posterior complex. This is the anterior complex. You can see the needle is going in plane. And what we will do is, we will, instead of adding an to the epidural needle. So this saline drip is nothing but a 500 ml saline bottle has been pressurized with 50 millimeters of mercury pressure. And as we cross the ligamentum flavum, you will see the loss of resistance. At the same time, you will see the saline also is flowing. So it's a dual confirmation. There is a loss of resistance with your tactile sensation. So in the same view, we are introducing the spinal needle as well. It is a combined spinal epidural where we place the epidural catheter first, and then we are introducing the spinal needle to reach the interlaminar space. So this is how we do a real-time ultrasound guided interventions using a paramedian cross view. So now, what is the success rate that we are looking at it? Whenever we do a real-time guidance, our success rate is almost 98%. More than that, the first pass. The first pass means without any manipulations, with a single pass, your ability to access the epidural space is almost 74%. And then the time that we required is about 52 seconds. You just imagine, most of these patients are difficult zone anatomy. The BMI is about 30, 35, and sometimes it is 40. Even in these difficult individuals, when you put them on prone, your needling time is only 50 seconds. The ability to access the epidural in one pass is about 74%. So this is about the performance when you do a real-time guidance. So now this is about lumbar spine interventions. We have seen ultrasound assisted, that is a box technique. And for real-time guidance, we have given one technique known as a PX view. Now we will look at the thoracic spine. In the thoracic spine, we have 9 windows. There are 5 longitudinal, 3 transverse, and 1 cross view. The 5 longitudinal views are this. Don't worry about the terminology. It is simply describes the target which you look at it. If you place the probe across the ribs, it is known as paramedian, sagittal, costal view. If you slide your probe and arrive at the costo-transverse junction, it is known as paramedian, sagittal, costo-transverse junction view. If you slide your probe little more medial, you will arrive at the transverse process. It is known as a transverse process view. From there, if you arrive at the articular process, it is known as the articular process view. From there, if you make an oblique tilt, you will look at the interlaminar space. That is known as an interlaminar view. Similarly, in a transverse view, there are 3 views are there. If you place the probe across the costo-transverse junction, it is known as a transverse costo-transverse junction view. If you slide the probe little below, you will see only the transverse process. Then it is known as a transverse process view. If you slide little further down, you will see the articular process. It is known as a transverse articular process view. The cross view is nothing but in the paramedian plane, you will rotate the probe by about 20 to 30 degrees. where you will cut three different parts of three consecutive vertebrae. Transverse process of the lower vertebra, lamina of the middle vertebra, the base of the spinous process of the above vertebra comes in a single line. This is known as paramedian cross view. So now let us look at, I will explain you individually. When you place the probe across the rib, it will cut the ribs like this, and the ultrasound image is going to look like this. You will see a clear-cut hyperechoic line with the shadows because of the rib, and in between the shadows, you will see a pleura. And then if you move the probe to the costotransverse junction, what happens is you can clearly see a step in the cephalad end of the ultrasound image, because where you can see the rib interacts with the transverse process. Here, this shadow is produced by the rib, whereas the posterior shadow is produced by the transverse process. Though this step-like pattern indicates you have arrived from the ribs to the costotransverse junction. From there, if you slide the probe little more medially, you will only see the transverse process, and the transverse process looks like this. And there is no pleura. Whenever you arrive at the transverse process, the pleural is reflected more in front, so you will not see the pleura in between the transverse process. Then from there, if you slide the probe little more medially, you will arrive at the articular process, where you can see this continuous hyperechoic line, because one lamina is going to interact with the other lamina. This is the articular process. From there, if you make an oblique tilt, you will see the interlaminar gap. So this is an interlaminar gap. So this is how the ultrasound image looks. Between the two gaps, you can see the posterior and anterior complex. When you go to the thoracic spine, the gap between the two lamina is very less, so you may not able to see these two complex consistently. So that is the limitation in the thoracic spine. It is not like lumbar spine, where we can clearly see the gap and the posterior and anterior complex. But whenever in the thoracic spine, both these laminas are overlapping, you may not be able to see the gap effectively. So at this point, if you just rotate the probe by 20 to 30 degree, what happens is then the ultrasound image cuts three different parts of three consecutive vertebra. Transverse process at the lower end, lamina of the middle vertebra, and then the base of the spinous process of the above vertebra lies in a single line. So this is how the ultrasound image looks, where you can see the transverse process at the lower end, lamina of the middle vertebra, and then the spinous process of the above vertebra on a single line. When you align like this, your epidural needle will go into the epidural space. It cannot go any other way. So this is known as a paramedian cross view. So now we will look at a transverse views. If you place the probe across the costotransverse junction, you will see the shadow like this, and exactly the ultrasound image is the same. And if you slide the probe little below, you will see only the transverse process. The image is going to be like this. You will see only the transverse process. And then if you slide the probe little more further down, you will see the articular process, and the ultrasound image is going to look like this. So these are all the three transverse views, distinct transverse views, where we can appreciate costotransverse junction, transverse process, and then articular process. And then this is a quick video where you can see all these things. This is a rib. This is a costotransverse junction. You can clearly see the step. This is only the transverse process. This is an articular process. From there, if you make an oblique tilt, you will see the interlaminar view. From there, if you make a rotation about 20 to 30 degree, you will see a paramedian cross view, where this is transverse process, lamina, and then this is the spinous process. If you make the transverse view, you can see clearly the costotransverse junction, where you are not seeing the pleura, then only transverse process. If you slide the probe little below, you will see the articular process. So these are all the three transverse views of the thoracic spine. Now we have seen the views. Now utilizing these views, how we are going to surface mark. For that, I am going to prescribe you one technique that is known as a box. How we arrived at a box in the lumbar spine, there is a box technique for the thoracic spine as well. We are in the process of publishing it. Soon that you will see these papers onto the online, you can access them very well. You just look at it, how we do it. So in this box technique, what we'll do is simply, through the paramedian sagittal oblique view, we mark the desired interlaminar space. This is Mills line 1. Then we will slide the probe and mark the next subsequent, then the spinous process line, and then we will mark the articular process line. So we will get a box like this. This box is nothing but the first horizontal line is your desired interlaminar space. The next horizontal line is one level below the desired interlaminar space. The midline is indicates the spinous process, and then the blue line, the lateral vertical line, indicates the articular process. So if you look at the box, it just defines the hemilamina of the lower vertebra. So you are going to introduce the needle in the middle of the hemilamina and direct towards the left upper end corner of the box. So you will enter into the middle, hit the lamina, and then make a cephalad tilt and as well as the medial tilt, so that you will focus or target the left upper end corner of the box. So that is how we are going to make our needle journey towards our desired interlaminar space. So you are going to walk a slight cephalad angle and then the medial angle. As we reach your epidural space through the LOR, we are going to introduce your catheter. So this is known as a box technique in the thoracic spine. So now we have seen how we use these ultrasound information to surface mark and introduce our needle. Now we are going to look at ultrasound guided thoracic epidural access. Ashish sir, am I audible? Is my slides are clear? Is everything is fine?
Yes, sir. Clear, sir. Everything.
Yeah.
Everything is
okay.
fine. Everything.
Now, now we are going to look at ultrasound guided thoracic epidural access. So as far as the ultrasound guided, I'm going to prescribe two windows. One is paramedian sagittal oblique window. Another one is a paramedian cross window. So now let us look at one by one. This paramedian sagittal oblique window has been introduced in 2009 by Professor Manoj Karmakar. That is the oldest ultrasound window through which we can look at the interlaminar view. And they have clearly established the real-time guidance is far superior than the landmark guidance. So how exactly it has been done like this is like this. Typically, patient is in lateral position and you take a curvilinear probe and place it on the non-dependent side and you get, these are all the lamina, these are all the interlaminar gaps, and introduce the needle from caudal to cephalad in an in-plane. You just look at the needle, how it has been introduced, and this is the needle, but you can appreciate the needle visibility is not that great because in the paramedian sagittal oblique view, the ultrasound window is going at an angle. So the needle is going into the interlaminar space. This is the interlaminar space. As you engage your needle into the ligamentum flavum, we add up a saline drip and then continue to advance the needle throughout, seeing under the ultrasound. As we get a loss of resistance, we will appreciate the saline drip as well. Then we will introduce our catheter. This is a paramedian sagittal oblique view. So now you have appreciated the needle visibility is not great in the paramedian sagittal oblique view because the ultrasound goes at an angle. So to overcome this difficulty in needle visibility, we explored and come across the paramedian cross view is the most optimal ultrasound window for better needle visibility. Here, the probe is rotated by about 20 to 30 degrees. It is not tilted. It is only just rotated. It is rotated like this. So that where these three consecutive different parts of three consecutive thoracic vertebra is aligned in a single line. That means the transverse process of the lower vertebra, lamina of the middle vertebra, and then the spinous process of the above vertebra will align in a single line when you make that cross. So because of the needle visibility, there is no tilt, the needle visibility is better. Here we place the patient in a prone position and then scan from lateral to medial. As we rotate, we will get these three targets aligned. And then you will introduce the needle in a in-plane from caudal to cephalad. You can see the needle visibility is very good. And this is the gap in which you need to introduce your needle. As your needle goes in the gap, you add up the saline drip and advance your needle under real-time guidance. And once you get a loss of resistance, you can see the saline drip also is flowing. That confirms your needle entry into the epidural space. You can see why we call this as a cross view, because the probe crosses the midline in the upper 1/3. The remaining 2/3 of the probe in the paramedian axis. So this is known as a paramedian cross view, through which we are doing a real-time ultrasound guided interventions. Now we have seen the thoracic spine. Now let us look at utilizing which view to choose, paramedian sagittal oblique or PX. We have completed an RCT where we clearly found the first pass success rate is far greater in the paramedian cross view. The needle visibility is better, and then the crossover to the other group is extremely less. It's simply because we are not tilting the probe, so the needle visibility is better, our performance is better. So now coming to the cervical spine interventions. Through the same paramedian cross view, we can access the cervical spine as well. So in this view, you can see we are doing a C7T1 intervention for a radical thyroidectomy, where you are going to rotate the probe similarly between C7 and T1. So here you can see this is a C7 and this is a T2 transverse process, T1 lamina and C7 spinous process when you are rotating. Once you get your probe aligned to these three targets, if you introduce the needle in plane, it is easily go into the epidural space without any wear. As you approach the ligamentum flavum, we usually connect a saline drip, and then we will advance our needle, continue to advance our needle. As we enter into the epidural space, we can see the free flow of saline. So once our saline is free flowing, then we will disconnect and introduce our catheter. So our needling time is reduced to about less than 50 seconds. So far we have seen a lumbar spine assisted, real-time guided. Then thoracic spine assisted, real-time guided. Now we have seen the cervical spine, real-time guided. Now we are going to look at how the caudal, the ultrasound help us to do a caudal interventions. As you all know, these are all the 4 questions that we wanted the ultrasound to help us in caudal. We wanted to see the sacrococcygeal ligament so that we will pierce it. And we wanted to see the thecal sac inside the epidural space so that we can avoid going into the thecal sac. And the third thing is, if we can able to look at the drug spread, we can judge how far our local has gone. And then if we can locate our catheter, if you are introducing the catheter, that is well and good. Now let us look at whether the ultrasound help us to do that or not. So here you can see this is the sacrum, and that is the sacrococcygeal ligament. You can see our hypodermic needle crossing the sacrococcygeal ligament, and we are injecting the local anesthetic. This is the phylum terminale, and you can see a clear hypoechoic local anesthetic. As we inject, you can see the dura is getting splitted upon from the ligamentum flavum, and it is getting depressed, you can see very well. In the transverse view, as we inject the local anesthetic, that is pulsating spinal cord, you can see the unzipping of the dura mater from the ligamentum flavum. You can see the dura is getting squeezed against the spinal cord. This is our local anesthetic. It's completely squeezes the spinal cord, and we can clearly see our local has come up to this range. If you move your probe in a cephalad directions, we can trace how far the local anesthetic is spread. So in this space also, the local anesthetic has come. And in the above space, you can see clearly this is the dura and the local has come. It is not completely squeezed to the spinal cord. That means the local has come up to this segment. Similarly, if you inject, if you thread the catheter, the ultrasound also will tell us where our catheter is being introduced. So here we are going to introduce the catheter. This double line is a catheter. As we introduce, you can see, and then as you pull out, you can see the catheter is coming in, and then as you introduce, it is getting jet out from the needle. So through the transverse view, we can see where the catheter is moving when you jiggle the catheter. So you can see the movement. So by this, we can ensure till what vertebral level our catheter has been moved. So these are all the ways in which the ultrasound can help us in our caudal anesthesia as well as catheterization as well. So now, some of the difficult situations which we come across, I wanted to share with you. You know that these sort of an obese patients we come across quite commonly. They are about 30, 35 or 40 BMI. They are all lower limb fractures. We desperately need spinal. But when you palpate their back, you don't have any landmark that you can reliably appreciate at the back. Here, ultrasound helps you like a magical way, where you can see the targets and then mark. As you see here in this interventions, I am doing a para-articular process approach, where we will mark the box and introduce the needle at the paramedian space, and single pass will be able to access the intrathecal space. So whenever the landmarks are difficult, they are not helping you because you couldn't able to see them clearly, ultrasound will help you to mark these things onto the surface, and you can do your central neuraxial block effectively. This gentleman has a severe ankylosing spondylitis. He is posted for total hip replacement, where in previous 2 institutes, they couldn't able to put a spinal because they have 4 or 5 consultants have tried more than 10, 20 times for 1 to 1.5 hours. They deferred the case. So when it arrived to us, we just used an ultrasound and marked the widest interlaminar space where we can get a space. And then we have used the Mills line through which I can able to introduce the needle in the first pass without any problem. With a one single pass through a 25 kg Quincke needle, we can able to perform the spinal. So similarly, in a scoliotic spine, if you look at this particular spine, she's a 45-year-old lady, short-statured with post-polio residual paralysis. His lumbar spine is completely rotated. At the back, if you look at, you will see only the transverse foramen. The vertebral body is rotated by 90 degrees. So from the back, you will look at only the transverse foramen. So how we did it? By using an ultrasound, we marked all the points. So once you look at the spinous process, articular process, lamina, transverse process, you can able to mark everything. What is the rotation? What is the tilt? So everything we could able to mark it onto the skin. If you look at, we can clearly able to get the box onto the skin. And then we are using a combined spinal epidural in these difficult anatomy. Suppose if you don't have an ultrasound, I don't imagine that I could able to introduce a needle like this in this complex spine anatomy. You can see the needle trajectory is almost unimaginable. It is exactly towards the left shoulder. And then we are doing a combined spinal epidural in these sort of a difficult spine anatomy because this confidence has been given by our ultrasound. So now, to sum up, the ultrasound guidance shows us all the relevant structures that are required to produce effective central neuraxial blockade. And then, as we see the spinous process, lamina, articular process, interlaminar space, the entire spinal column, you are going to perform better because so far this last 100 years, you have palpated only the spinous process and did your central neuraxial block. You have now 10 other different landmarks that is available to you. Definitely your performance is going to be better. It doesn't mean that we are going to use ultrasound for every single normal central neuraxial blocks. It is not. It's not required. But when you wanted to do and navigate a difficult situation, you should learn the lumbar spine sonography in a normal individual. Then only you can use the skill when the difficult situation arises. So that is why you need to perform minimum 50 normal central neuraxial block, understand the zone anatomy, then only you can navigate a difficult situation. To sum up, you all understand or know, August Bayer has introduced a spinal anesthesia in 1898. Now we are in 2025, almost 126 years have passed. So far we were blind. We only palpated the spinous process at the back. And we have given all our explanations for all our success and failure. But now the ultrasound gives us a third eye to look at. There are 10 other parameters we can see. With that possibility, I have shown you now what are all the things are possible. So with that experience in the last 5 years, how our central neuraxial blocks have been transformed, how I am look at in the next 10, 15 years is central neuraxial blocks are going to take the center seat again. It is going to push away all the peripheral nerve blocks to the periphery, and then the central neuraxial blocks are going to take a forward seat, because now we can access every single intervertebral space with precision, intent, safety, and efficacy, and place the catheter precisely whichever the vertebral space you are described. I can able to access them within about 30 to 40 seconds with single pass, effectively, safely. And then I can place a catheter, and I can dose it from pure analgesia to complete surgical anesthesia. I can prolong it and keep it for 2, 3, 4, 5 days, whichever you want. So this possibility has never existed before. This is available to all of us with the availability of ultrasound guidance. So I request all of you to embrace this technology so that you will see entirely a new world of central neuraxial blocks in your practice. So thank you very much for your kind attention. That concludes my presentation. Thank you very much, Ashish sir, for giving me this wonderful opportunity. Back to you, sir.
Thank you. Thank you, Shiva, for this wonderful presentations. And with all these camels and horses and trident, we learned so many.
There are many,
yes.
many terminologies.
Yes,
true.
That
These are all
fantastic.
to begin with. It looks complex, but as we take this journey, and everybody will get it, because that is how we started our brachial plexus and the other plexuses. Now you know where are we. And similarly, spine we have started now. In next 5, 10 years, it is available to everybody.
Yes, absolutely. And as you said, just sit back and relax and enjoy. That is exactly what we did. And it's impossible to remember all the things that you said. So we have to see it again and again, and do the do the
precisely because I know very well the scope of the presentation is to just to give you the spark, to just to showcase you where we have come. It is not to train you. It's not possible. It is very difficult to understand because many new terminology, techniques, it's not possible at all. It is to give you a gist how far things have been transformed from lumbar, thoracic, cervical, caudal, and the precision, the safety, the comfort is phenomenally changed, especially in a difficult situations. Once you are privileged like this, you see the scoliotic spine. It's in my experience, it's completely transformed.
And also the that spine, that bamboo spine, it was tremendous.
Yes.
So yes, it was lovely, and thank you very much. Thank you again for this wonderful presentations. And Shiva, can you just close your screen?
Stop share, and so that we can look at the questions.
Thank you. And we have here almost 80-85 participants at one point. So it was really, I think, helped everybody to learn and see and to open their mind to this neuraxial sonoanatomy. We have many distinguished delegates here, and I'll request one by one to have some comments on these presentations. I'll start with, of course, my teacher, my mentor, Professor Iqbal sir. Sir. Sir, you are muted.
All right now. Okay, thank you very much, Dr. Shiva. It's a very impressive presentation.
Thank you very much, Iqbal.
It's way over my head because I'm not practicing anymore. But nevertheless,
no worries.
What I've seen, is intriguing, and I'm sure many of the participants who are here are already practicing this, and will be again our second time impressed with your specially named curves called cat, horse's mouth, and other things which I just forgot. But nevertheless, I'm very much impressed. Very impressed. I wish I could be with you to do all these things now, but I'm a watcher now. I think I will enjoy watching this more to come. Thank you very much again, Dr. Shiva.
Thank you very much, sir. Thank you.
With your permission, I want to leave now.
Thank you, sir. Thank you for the opportunity.
Thank you, sir.
Thank you very much.
Thank you.
Thank you.
So as Iqbal sir said, I mean, we are all just serving time. I know very well. I looked at the PNS. I did landmark guided. Now I'm using an ultrasound. I know how the future is going to change.
Yes.
So, but every single time we are just serving our time with our best of our efforts and knowledge.
Right.
So
absolutely.
this is the time that we have ultrasound as a toy to us.
We are passing through a generation where we saw everything.
Yeah. Yes.
From total landmark to total ultrasound.
Yeah.
So it's wonderful. I saw here Dr. Dasgupta from England. Are you here?
Yeah, I'm here.
Okay. Any comments, sir?
I wrote in the comments, Shiva is always great, and very few people.
Thank you very much, Dasgupta sir. Thank you very much. Nice to see you.
I met him in Aura. It's amazing. His knowledge is awesome, and he's one of the few people I think in the world who has a PhD in regional anesthesia. I don't think anyone has it.
Thank you, sir.
Yeah.
Why ligamentum flavum was not visible sometimes in ultrasound guidance? So that's the one question I just saw. Dear Rafson, you know that whenever we do a low frequency probe, the resolution is poor as we go deeper, more than 3 to 5 centimeters. So the ability of ultrasound to discriminate between ligamentum flavum and the dura mater is not there, because the resolution, the physics is so poor because the ultrasound can't discriminate. So what happens is, for the ligamentum flavum and dura, instead of 2 white lines, it put it as a single line. So it's not a 2 different line. In very thin individual, where if the target comes less than 2 centimeters, you can see them as separately, but more than 3 centimeters, they look like one. So because of this, we call this as a posterior complex, because it represents ligamentum flavum and the dura. So that is why we are calling it as a complex. So why we couldn't able to discriminate is the resolution of the ultrasound beam in the low frequency probe is poor. It couldn't able to discriminate 2 different structures as 2 different. So that is why we couldn't able to discriminate.
Thank you, sir. Thank you for your explanation.
Yeah. Any other questions? I just scroll up. Yeah. Okay, that is
everything is excellent presentation. So
I know because it's very complex. I know very well. That's why I said in the first presentation
itself, you have done it so well.
So I wanted to just give them
this clear and palatable. So that's
yeah. So there are many things to showcase, and there are many techniques are possible and difficult interventions. It's really exciting.
Right.
So I mean, you can keep it on record. It is going to change our practice.
Everybody was so engrossed that there's no more questions. So the floor is open. Anybody wants to make any comment?